Representative Johnson.
Thank you, Chairman. Dr. Silva, and I appreciate the comments that just came out of this panel with regard to Representative Schofield's. We are not talking about elective abortion.
Correct.
This bill is not about choice.
Correct.
This bill is purposely a bipartisan bill addressing an issue of medical exceptions. Because if it were not, we would be talking about rape or incest or fatal fetal abnormality. This is not a choice bill. This is a medical exception bill, correct?
It's a bill about medical care, correct.
About medical care, and it is attempting to separate us from a highly politically charged debate. And so I want to talk about that, if you don't mind.
I don't mind.
You are not an activist.
Correct.
You're just a straight-up physician. You are not ready to go to prison to serve a political point.
Correct.
And so when faced with real cases, not hypothetical, not why are we here, Navia Crane, who the morning of October 29, 2023, her mother of this 18-year-old girl was screaming in emergency room, do something, because her daughter was having a miscarriage with a 6-month fetus. 2 emergency rooms over 12 hours turned her away, telling her that they could not perform the health care because of Texas laws. That's true. I appreciate the panel answering the questions. This is not hypothetical, these are real. And I want to talk to you about that because as a physician, viability is at 25.2, right? Or wherever you want to say it. I'm asking you guys, at what point can you deliver today and feel comfortable that you're not facing the risk of existing laws on an abortion?
Every hospital has a number that is best for that hospital situation. If the hospital is in a more urban area with a highly ranked NICU, that number may be as low as 23 weeks.
Okay.
If a woman is at 24 weeks, perhaps in a different situation, in a rural situation, in an emergency room that doesn't have a high-level NICU, that number could be different.
And so on a case-by-case basis, physicians need to be able to make that call based on what's available to you at the time, and it's not even factoring in your intent, right? You're not abortion doctors. You're OB-GYNs, you're emergency room physicians, you're trying to provide care. You're not trying to perform an abortion, yet you don't feel any space to be able to defend yourself and say, hey, I'm actually trying to save the life of both individuals here, but you face liability, correct?
Correct.
This question is directed either, again, I apologize for the first names, either Heather or Lisa. We keep saying remove liability, and I want to take us back to what kind of liability we are talking about. We are not talking about liability, like my insurance company can pay my claim. We're talking about life in prison in criminal punishment. We are talking about a separate $100,000 fine that can be prosecuted by the Attorney General separately. We are talking about SB 8, the bill that allows any individual who thinks they have a dog in this fight to haul you into court through a litany of discovery and risk of financial ruin to the physician and the hospital.
Correct.
And the reason that we're here, in part, is because the United States Supreme Court withdrew Roe versus Wade, correct?
Correct.
And when the United States Supreme Court withdrew Roe versus Wade, and so go back to the states and deal with the state laws, at that point, honestly, laws that nobody ever thought would go into effect popped up.
Correct.
And so now, because the federal government has said go back to Texas, we are now confronted, as the Zawoski case shows us, with multiple liabilities. Correct?
Correct.
And those, as you stated earlier, those statutes have differing definitions, differing consequences to the physician. And so, Heather, as the individual for the hospitals, when these laws came down and went into effect, what has it been like trying to give guidance to where this line is that is keeping physicians from being able to feel comfortable that they can make the determination and say, I'm in a different hospital setting, this patient's at a different week in a miscarriage, and that they're not intending to perform an abortion?
I mean, I don't have direct knowledge because obviously I'm not on the front lines and an in-house attorney, but what I can tell you is that, once you are faced with 4 different statutes, Chapter 171 has a specific definition for medical emergency. It's similar to 170A, but it says as certified by the physician. It doesn't have reasonable medical judgment. And then you have 170A, which was the law that went into effect 30 days after, I think, Dobbs came down, and that was the reasonable medical judgment, and as we're litigating here today. And so essentially what you had to do as attorneys is figure out, okay, what am I dealing with? Where am I looking, et cetera, et cetera. Essentially, the other thing too that is not really talked about a lot, but is in the Code Construction Act at the very end. I think it's section 311. Well, I'm not going to quote it because I can't remember. Sometimes I can memorize these things, but not all the time. There is a section in there that says the passage of one abortion law does not act to repeal another. And then the medical board, when they issued rules, said, okay, physicians, you need to comply with 170A, 170, 171, all the rules that are related to abortion, and every court case and opinion and ruling that could ever be handed down. And so we have to imagine laying it out all on the table and figuring out, okay, how do I make sure that I can act in this situation or this situation and this situation? And so making sure that, for example, the heartbeat bill, was the 6 weeks, if there's a heartbeat present, but there is a medical emergency exception in that section. There is a medical emergency exception in the informed consent, for example. You're not going to stand around while someone's bleeding out waiting for them to sign papers. And so all of that was there. And so what we're just trying to do is make sure that medical emergency in 171 and medical emergency, there's not a definition of medical emergency in 170A, but it's all the same. So that now I know I go from picture a whole bunch of different papers on a wall. I go from having them all up on a board to one.
And that's what you're describing right now as a lawyer trying to parse through effectively almost 100 years of prior Texas law and giving guidance on where the path is. And that's not happening right now, right?
I think it's hard to do so. And I think, again, being able to put in the law that, communications to try to make sure that we're acting within reasonable medical judgment, that you're meeting the exceptions, aren't going to constitute aiding and abetting. Again, it's just alleviating that delay and just making sure that we all understand. When you have a serious penal penalty or civil penalty, it just helps to you need to speak with clear language. And so if we're going to have multiple statutes, they should try to harmonize and be as similar as possible. And so that's what we're trying to do.
Yeah, let me just add to that. Under code construction, that's what we would be required to do. We're required to take all the different statutes and try to harmonize them together. Mm-hmm. So what we try to do in 44 is say, okay, let's have one definition across all of the statutes so that there's not piecemealing, which is kind of what Heather's talking about.
And the definition of reasonable medical judgment is a foundational definition that we have across our laws in the state of Texas. So we're actually just creating consistency within all codes by
That's
this
correct.
definition.
Yeah.
And it's what the physicians are accustomed to, correct?
Correct.
Okay.
And it's an objective standard, by the way.
Explain what that means.
It means that, reasonably prudent, it's not a subjective belief. So in other words, I think the Supreme Court in Zawoski outlined very clearly, no reasonable physician would have made the same decision that this physician would make. So that's what that means.
Yeah, one of the areas that you can see where this sort of conflicts or you're trying to harmonize is that one of the statutes says use good faith. So good faith and reasonable medical judgment are not the same thing. So what we're trying to do here is say reasonable medical judgment is the objective standards. Good faith is somewhat of a subjective standard. So we're adding the objective standard all through the four different laws.
And Heather, you said what we're litigating today, and that's one thing I want to be real clear about. We are not litigating. And that is part of the problem, right? Right now, like the Zerwoski case, the physician was able to get a determination based on whether or not Paxton could pursue them under the $100,000 threat created by the trigger ban by the Texas legislature in 2021. But these questions of all these other laws and creating this clarity, the Texas Supreme Court and the medical board have been very clear to us that it is our responsibility to clean this up and stop waiting for piecemeal litigation to go through, because currently women continue to die, correct?
I don't have any direct knowledge of anybody that's died since the Zerowski opinion, but
I know, and part of that is, you said earlier, and I don't want it to go missed, HIPAA. HIPAA says, y'all as the hospitals and the doctors, you have to protect the patient's privacy, and unless the patient will come forward and tell their story, it's not told, right?
that's correct.
And I don't want that to be perceived in an absence of information, because the law protects the medical community from being able to scream from the rooftop what's happening here, correct?
Arguably, yes.
And in fact, we haven't gotten our maternal mortality or morbidity numbers despite legislative requirement for that data to be released. We're still waiting on that information, and that's why we heard a bill last week about trying to clear this up, because we don't have good data on this in Texas. If you can answer that question.
I'd have to confirm.
And if you can't answer that question, I'm going to come back to the brave individuals who have been willing to tell their story, like Gisele Barnica. She was 28 years old. She had a child at home. She was 17 weeks pregnant. And again, she died because in a miscarriage, there was a heartbeat. Unfortunately, this was September 3rd, 2021. If this young woman had ruptured just a week before, she would be living. But because of SB 8 and the passage of SB 8 and the threat of the heartbeat bill, while intended to save lives, actually destroyed a mother and denied a child the mother who was raising her for a 17-week miscarriage that physicians, there's no way that fetus could have ever been viable. Will you please answer that question?
Correct.
So in the political attempt to be pro-life, we have actually increased maternal death. You don't have to answer that. Portia Anumzi, 35-year-old mother, child at home, 11 weeks. Again, like it or not, and Heather, you said it, we're not trying to do judgment, because these are not politicians, these are not activists, these are not people that want to risk their life in prison. But the threat of prosecution is very real on the healthcare community, correct?
That's correct.
It is absolutely chilling behavior.
I mean, we're supposed to comply with all the laws and regulations, so in order to do that, we need to understand and make sure we know what we're allowed to do.
And in the last 4 years in this state, we haven't asked one physician to risk their life in prison to help us solve this problem, right?
Not that we're aware of.
And because my colleagues say, well, we're not really prosecuting. If I can ask Dr. Silva, does it make you feel comfortable that we haven't yet sent one of your colleagues in a white coat to prison to put you out on a limb to be the first one?
That would not make me comfortable.
And in fact, Attorney General Paxton, after the Dobbs decision, put out his proclamation that he would vigorously pursue each and every potential law that was on the books, correct?
Correct.
Can the two of you tell me, has that threat of both financial ruin and life in prison caused our medical community to question your reasonable medical judgment in face of a pregnancy complication?
Thank you for the question, Representative Johnson. I would answer that question first at a high level, and I would say that any person, any professional doing what they do for their livelihood would find that circumstance challenging, and doctors are no exception. To the cases described, I know of them in general. Again, I don't know the medical details well enough to comment specifically, but I want to repeat the point that I made earlier is no one wants stories like that in our state. No one wants a negative outcome. No one wants to see a young woman in the prime of her life at what would otherwise be the most joyous time in her life to have that kind of an outcome. And if this bill will help physicians to treat those patients appropriately so these stories go away, we are absolutely in support of that.
And in your view, unless we pass this bill, these stories do not go away, do they?
This bill would be a sizable step towards the goal you just described.
Heather, in your view, do these current laws make it harder for hospitals to fulfill the duty of care to patients?
I think it makes it challenging in the sense that you need to understand how they all work together and understand what definitions you're working with and understanding what you are allowed to do and not do in order to make sure that your protocols and the guidance and what you can do when you get these questions or these situations arises. I think it does make it more difficult, and so that's part of why we're here today. Again, conforming to one definition, clarifying the definition of ectopic pregnancy to include, if they are implanted an intrauterine scar, making it very, very clear that when lawyers, doctors, health nurses are discussing and communicating about these cases, they don't have to worry about someone deciding that they're going to sue them, because that is not considered aiding and abetting if you're trying to work through the exception. Again, this is not any sort of expansion of any sort of anything. It is just to make sure that we have one standard, and so that we can go back and make sure that everything is clear. We can provide guidance, and then the education too will also help, right? I mean, that is going to be the state bar, the medical board, other professional organizations, and other, other stakeholder groups to all come together and make sure that everybody understands, once and for all. And that will be, CLE and CME, and that is very important. And so finally, I think people feel that they can talk about these things without fear of prosecution or repercussions. And so I think, to answer your question, we wouldn't be here today if it were easy. So it is difficult.
Anecdotally, I have heard from many that these laws are impacting recruiting of young women and professionals into our state in general. I have friends that will say they are grateful that their daughters are spending their 20s in other states because they are concerned that in a pregnancy diagnosis or complication, even though they are not seeking an elective abortion, they cannot get the care that they need here. And we are seeing that recruiting impact across all professions when it comes to the state and our economy. But I want to ask you specifically about OB-GYNs. Are you seeing that these threats of prosecution, this litany of civil and criminal liability against physicians trying to use their reasonable medical judgment, is keeping this state from recruiting the best quality of physicians for the future of every Texan?
So what I can say is that, in hearing from anecdotally from our hospital leadership, right or wrong, there has been it is now a significant challenge to try to recruit OBGYNs to come to this state. It's just not happening, is kind of what we've been hearing. As far as numbers are concerned, I don't have specific numbers from THA, but in looking at the Bureau of Labor Statistics, in 2022, Texas had 1,550 OBGYNs. As of 2024, that was 940. That's approximately about a 39% decrease.
And that impact
And so it's
ripples.
basically to the extent that someone feels that they can't come and practice here because they're afraid or whatever the case may be, they're confused. The hope is with HB44, we alleviate that fear, we alleviate that confusion, and so that they'll feel comfortable to come here, not retire, or whatever the case may be, because they know the standard that they are dealing with, and that they can use their reasonable medical judgment, evidence-based medicine to treat these patients.
And we have seen that, again, reporting is, we've seen a 56% increase in maternal mortality since the passage of these laws. We don't have clear data because the state is not producing the data. You cannot give us data because you have HIPAA. We're dependent on people telling their story. And again, in this recruiting, this anecdotally impacts women's health care across the board, regardless of an issue of choice, correct?
I mean, if the less OB-GYNs we have in the state, the less access we have.
And I do want to ask this question because this is not a choice bill. This is not an elective abortion bill. This is a medical exception bill attempting to address this current crisis of confusion within the course of Texas statutes that were opened by Dobbs to clarify medical exception and medical exception only. Is that correct?
That's correct.
And Ms. Kaufman, there's been talk about a 1925 provision and whether or not this is an attempt to backdoor revitalization or recognition of that law.
So I can't tell you whether or not 1925 is revived or not revived. In fact, a court will probably have to tell you that, and there's some cases out there that ultimately will get to that opinion. I can tell you that if the 1925 law is still active and a good law, that we need to have the exception in the law so that all of the statutes, all four of them, conform to each other. If it is not good law, then sort of no harm, no foul. It wasn't, I don't know the answer to that question. Mm-hmm. The court's going to have to tell you the answer to that question. But in terms of what we're trying to do, in order for the medical community to have the protections that it needs, in order to change their behavior and act in a timely manner when you're dealing with pregnancy complications, all four statutes need to be changed so that they mirror each other.
And we do know that Attorney General Paxton is threatening that 1925 law?
That's correct. Attorney General Paxton has sent letters to practicing hospitals and physicians about that.
And if the Texas legislature wanted to reaffirm that law, the Texas legislature could pass and reaffirm that law, and this bill is not doing that.
Correct. This bill is making a conforming change to all four statutes so that the standard of what a medical exception is and the exceptions to it, that's all this bill is doing, is making those conforming changes to 170, 170A, 171, and the 1925 law.
Thank you. And physicians, getting back to not only this issue of reasonable medical judgment, the issue of serious bodily injury. We talked about the fact we should not ask a mother to suffer and be put on a transplant list. Explain that.
Cardiac function, potential for cardiac transplant, certainly if a mother has pre-existing cardiac conditions, and a pregnancy could potentially harm her enough to put her in that position, yes, that is possible. The same with renal function.
And those sound like same 7 weeks pregnant and diagnosed with glioblastoma.
Glioblastoma is, for those who may not be aware, a very, very, almost always terminal brain cancer. Some with a very short lifespan ahead of them, some with slightly longer, but a glioblastoma needs to be treated in order to offer the person who has it some sort of life expectancy. And treatment can be surgical, but treatment nearly always involves radiation.
When I was little, I was taught that you run to a police officer in blue, that that's who you go to for help. And when I see your white coats, I think about that patient care room in that space where I have the ability to sit with you and seek counsel. And your oath is to do no harm. 7 weeks pregnant, glioblastoma, 3 kids at home. It sounds like the most grueling, challenging, moral debate. Can you get me to viability for my child? Or can you get me 3 more months with my kids at home? I can't imagine being in that position.
Yes.
Right now, are you able to have that debate free of legal or political interference?
Currently, I think that pulling all aspects of care for a woman with glioblastoma, a radiologist, radiation oncologist, a oncologist, a neurosurgeon, along with an obstetrician, gynecologist, maternal fetal medicine specialist, together to put their expertise on the line to make decisions about this woman's choices. She does have a choice. We don't know. We don't know her lifespan, but we can give her our best judgment along those lines and come up with some opinions. Do we, in any of these situations, have tough decisions to make, as does she? HB44 will absolutely help us to come together as a group to best advise this woman without fear of possible criminal and civil prosecution.
Because until this bill passes, you don't have that exception to deal with the issue of cancer diagnosis and to be able to make those considerations with the patient free from somebody effectively, like a politician, putting themselves in the patient care room.
Certainly, the diagnosis gets made, but our management of that diagnosis leaves a burden on our shoulders currently without change.
I want to be real clear, that burden is risk of life imprisonment and a $100,000 fine and an onslaught of civil litigation from anybody outside that patient care room based on the Texas laws that have exploded because of Dobbs.
And loss of licensure.
Yeah, and lose your license.
Yes, ma'am.
So currently, our healthcare profession, the white coat, is bearing the entire burden of this debate.
Much of it.
Thank you, Chairman.
Okay, thank you.